Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today is a really great conversation with Dr Andy Hilton, a GP partner in Sheffield and Chief Executive of Primary Care Sheffield, a not-for-profit company owned by the city's GP practices. Primary Care Sheffield was recently highlighted in the government's 10-year plan as an example of successful neighbourhood working. In this conversation, Andy explains the origins of Primary Care Sheffield, how it has worked to support practices, and the wide range of services it now provides. He discusses the benefits of working at scale, not just for patients, but also for practices and the wider health system, and how this approach can help tackle local inequalities. Andy also offers his thoughts on the move towards a neighbourhood NHS, why he believes general practice will be crucial to its success, and the challenges that lie ahead, including estates and the demands of an ageing population. He provides some really valuable advice on how to work more collaboratively with other practices, PCNs and partners in the healthcare system. Before we start, just a quick message from our colleagues on MIMS Learning. In-person learning is a vital part of keeping up to date, enabling GPs and other health professionals to learn with colleagues, ask questions of expert speakers and benefit from networking. MIMS Learning's event page gives you details of all the general practice focused learning events, which will provide you with practical take-home points for your practice, along with CPD certification. Visit mimslearning.co.uk/pages/events to find out more. I'm really pleased to welcome onto the podcast now Dr Andy Hilton. Andy is a GP partner in Sheffield and Chief Executive of Primary Care Sheffield, a not-for-profit company set up by GPs in the city. He's here today to talk about what Primary Care Sheffield does and how what it does has helped improve health for people in the city. Thank you for coming on the podcast, Andy.
Thank you for having me, Emma. It's a real pleasure to be here.
So first of all, can you explain a bit about exactly what Primary Care Sheffield is and what you actually do?
Yes, certainly. So we're a social purpose organisation, a company limited by shares. Our shareholders are the 70 GP partnerships in the city. So we cover a population of around 600,000, 16 PCNs, 4 localities. And we're rooted in general practice in the values of the NHS. So all our income is reinvested back into improving the quality of care for people in Sheffield. And we're a key partner in the local health and care system.
So why did you set up Primary Care Sheffield and how did you go about getting it off the ground?
We were established back in 2015 to support practices. I think at the time there was a recognition that there were some things that could be done better at scale, that actually by working across all the practices, we probably had more capability. I think also there was an anxiety at the time. I think it was a time where Virgin and Sainsbury's were looking at sort of opening up general practices and, you know, a model that subsequently failed. And probably the threat of that pushed us into thinking, well, we do need to organise ourselves and make sure that we're collaborating. The threat after that was more around other parts of the system wanting to pick up and take over general practice, but mainly recognising that we could deliver some services for patients better collectively through a bit of scale and an umbrella organisation. Like many federations or primary care providers at scale, we were very lucky in the early days of our existence. We were successful in a bid for the Prime Minister's Challenge Fund. That attracted about 11 million for Sheffield. And that was really instrumental in giving us a bit of financial resource to get going and a platform. And that 11 million, we didn't just put it into general practices for transformation. That was part of it. But we had a really ambitious programme, something like 17 different project areas that engaged a whole range of stakeholders from the voluntary sector, community nursing, mental health, community pharmacy. And so what that did very early on in our existence is that it made us a credible partner in the system, an organisation that was looking to innovate and transform services, but critically also to do that in a way that engaged and integrated with other stakeholders in the city. And we've gradually grown since then in terms of the scope and the scale of our services and what we do.
Was it easy to get all the practices on board? Was this something that everybody sort of recognised they would benefit from? Or was it a bit harder than that?
We're 10 years this year in our existence, and sort of that's something to celebrate. And it's been quite a journey. And engagement with our core GP practices and with the LMC has been critical along the way. And we have a really good relationship with them. And currently a really strong mandate for what we do. I think there's always been ups and downs. It's never been completely plain sailing. What's critical is that I always remind them that we're their organisation and that we're trying to work across the layers of scale, not replace one layer with another. It's about playing to our respective strengths, and that message has stood us in good stead. Our model has always been to support the practices and ensure that general practice can flourish in the city. And I think through that scale, but also the recognition of the value of the smaller components, whether the individual practices or neighbourhoods. And in Sheffield, we had sort of neighbourhood models long before PCNs existed and long before neighbourhoods were sort of the current form that's being talked about in NHS reform.
You do run some practices, but you also provide wraparound services. What other services do you provide and how does that work?
Yeah, so broadly speaking, our approach has always been three overlapping circles in a Venn diagram, if you would. So supporting practices or delivering practices where that's appropriate, wraparound services, enhanced primary care services, and then system leadership, innovation and developing for the future. That supporting the practices is stuff like back office functions. We hold finances for a number of the PCNs, rescue and resilience, so stepping in when practices are struggling. And we've done a lot of work over the years where we might put in a caretaker manager or some additional clinical capacity for a short period of time and then step away because the partnership gets back on its feet and runs normally. Occasionally, that results in us picking up and taking over a practice because that's the appropriate thing to do. But then it keeps it within the sort of GP family of Sheffield. And we use those practices to innovate and then share the innovations with our shareholders so that they get to benefit from the work that we do as well. We have a training subsidiary, Primary Training Solutions, so that delivers a whole range of training for practices. We support research clusters across the city and employ some staff. And then the wraparound services would be things like enhanced access, which I think is probably bread and butter for a lot of federations, ARI hubs, urgent home visiting services. We run a COVID medicines decision unit, community gynae and women's health services, sexual health services. We're developing community diagnostics, so 24-hour ECG, spirometry. We're looking into things like digital rectoscopy. We've got a business case around that at the moment. We support elective referrals across 10 specialties, and in partnership with Sheffield Health and Social Care Trust, which is the local mental health trust, and Sheffield Mind, we're in an alliance contract to deliver primary care mental health services. It's sort of pushing at the front of really true integrated neighbourhood working. You know, it's done across the 16 PCNs. The PCNs put in a bit of their own resource in terms of ours roles. That probably is about £1.5 million worth of staff from the PCNs themselves, plus other transformation money. So that's dealing with people with significant mental illness, but that don't meet the criteria for secondary care mental health services. And then we also have a domiciliary care subsidiary. And then the other bit of what we do is lots of system leadership work.
Are some of those things that would have previously been provided in hospitals, is this kind of a way that you see care moving out of hospitals into the community via a system like you're operating in?
Yeah, absolutely. I think the pressure on the system is huge. The more we can streamline and make sure that patients are seen at the right level, the better. For example, things like the sexual health services and community gynae women's health. It's about recognising that there are skills, experience that sit in general practice that we can share across all the practices, and that actually there are primary care clinicians, not just GPs, but others as well, where they do want to develop portfolio careers. They can do more. Lots of care doesn't need to be done by a specialist in a hospital, and so everybody gets to benefit. The specialists see the things that only they can see and deal with. Patients get care closer to home, and GPs get access to services nearer to where they're working and in a more timely fashion. So it feels like it does benefit each part of the system and, most importantly, patients as well.
So you hold the contracts for these things, but then do you devolve the work down to the individual practices to do it? Is that how it's set up?
A mix. So, for example, the sexual health would be a good one where previously all the practices were doing various bits of sort of sexual health and family planning. The local authority recommissioned a service and we jointly bid with actually the acute trust. So they run the specialist end of a sexual health service. We run the primary primary care end of it. And some of it's done at a hub level by our staff, both in and out of hours. And then some of it is delivered by either individual practices or PCNs where they have the capacity and the capability to do it. The important thing is it's all governed once. So there's a robust sort of framework of clinical governance and safety wrapped around it. So the commissioner's reassured that there's a consistency of service.
You were mentioned in the 10-year health plan, which has just been published, and you were mentioned as an example of neighbourhood working that's successful. You've touched on neighbourhoods. What are some of the benefits of working in this way, as you can see it, and how has it helped improve patient care?
There is a wealth of experience and skill and knowledge that sits in general practice. Often it goes unnoticed by other parts of the system because GPs just quietly get on and deal with it for their patients. And it's the ones that hit secondary care where perhaps there isn't that level of skill, then we get criticised about. But the problem is often that skill set is trapped within the walls of an individual practice. So you might be able to ask your partner down the corridor with an interest in something about a problem, but if you're in the neighbouring practice, you can't. And so our approach of cases has always been about using peer reviewers with an increased knowledge and skill set, backed up by consultant mentors, I hasten to add, so the specialist input as well. Therefore, they're able to sort of share that skill across all of the GPs in the city. And that means that patients get a benefit because we're all operating at a higher standard, even if it's not an area where we've got a specific interest in. It improves quality. It reduces waits in secondary care because secondary care are only seeing the patients they need to see. For example, recurrently over the last sort of 8 or so years that cases has been running across the 10 specialties as an average, we're avoiding probably about 12.5% of the referrals ever needing to hit secondary care because there's advice, guidance and education for GPs so they can manage it out in the community. Occasionally, we actually, as peer reviewers, will upgrade a referral to a 2-week wait where we actually think the symptoms are more worrying than the GP might have originally suspected. Education is a huge part of it. I mean, it's really keen to say this is not referral management. That's not what it's about. It's about upskilling, educating, feeding back. Through our training company, we run the Protected Learning Initiatives for Sheffield, which is sort of 6 or 7 events a year. The information, the data that we collect through the 10 specialties and all those referrals, we then use that to direct and target educational events that are based around the sorts of symptoms or groups of symptoms that GPs are referring and the common themes that the peer reviewers are pulling out where there might be a gap in education that we can sort out. And things change rapidly, don't they? The evidence base changes and we can't all keep on top of all of it, no matter how diligent we are. So it's just a way of sharing that knowledge, hopefully in a supportive, non-critical way so that GPs benefit.
This comes up all the time about the interface between primary and secondary care and primary care and other bits of the system.
Yeah.
Does having an organisation like Primary Care Sheffield, has that helped you improve relationships with other bits of the sector and help address some of those problems?
At times we are the sort of middleman between general practices and other parts of the system. That can be quite hard work at times, but primary care mental health would be a perfect example where Primary Care Sheffield is trying to bring together the governance of a large foundation trust as a mental health trust and general practice, and probably somewhere in the middle is the right place to be. We actually hold the CQC registration for primary care mental health, and it's therefore managed through our internal governance systems. And that's meant that the Commissioner and the Mental Health Trust and Sheffield Mind have dealt with one organisation, i.e. Primary Care Sheffield, and all the practices have had us on their behalf, representing them in meetings and developing the services, either the Commissioner or those other providers. Yeah, it does help.
So you've got all these practices. How do you ensure that you kind of represent all of the views of everybody that are your shareholders? And also, what's your relationship with the LMC? What do you do and what does the LMC do?
Well, that's a really good question and very insightful. We've always been very careful not to step into the role of the LMC. We're a provider at scale and we represent the interests of our shareholders. And our shareholders are able to vote non-exec directors onto our board, so they've got representation at a board level. We engage with them through all sorts of communications, regular meetings, and we have regular catch-ups with the LMC exec. And over the last 12, 18 months in Sheffield, we've developed a GP provider forum. So that's Primary Care Sheffield, it's PCN, CD representation, it's the LMC and locality representation. So all the layers of scale in the city sit in a forum And there's really good relationships. We've built trust by working together over a period of time. And I think that really has helped galvanise general practice leadership. As Primary Care Sheffield, we're not about GP contracts or representing from a contractual point of view. That's very much the remit of the LMC. We're about working out how general practice works with wider system partners and commissioners to deliver services in the best way possible for the patients of Sheffield. And that might be at an individual practice level, PCN neighbourhood level, or it might be at a citywide level by PCS. But the fact is it's all interdependent and integrated.
There's a lot of chat at the minute about primary care provider collaboratives, and you are effectively something like that, aren't you? And this idea that these are going to become more and more important as we move towards neighbourhood working. What do you see your role as being as time goes on, and particularly as ICBs are sort of cutting back on the functions that they provide? Do you see yourself as taking on some of those things for practices?
There's two questions in there. So the first one around the primary care provider collaborative. So I actually chair the South Yorkshire equivalent as Primary Care Provider Alliance, but it's the four places in the ICS coming together. It's the four professions in primary care, so GP and dental, pharmacy and optometry colleagues. There's representation from their respective representative committees. As a collaborative, as an alliance, it's very much about working out how we integrate across primary care and work better with across the different professions within primary care, working out how we collaborate with other parts of the system, so the Acute Federation, the Mental Health Alliance, the Cancer Alliance, high-level strategy about high-level principles that can be adopted in each of the four places. So it's not an entity, it can't hold contracts, it hasn't got a bank account, it doesn't employ staff. There's lots of forums that are collaboratives that are like that, looser sort of formations, part of possibly the governance of ICBs that are influencing on behalf of primary care collectively. In our alliance collaborative, each of the four places have a federation like Primary Care Sheffield. They sit there as well as providers. That's the subtle difference, is that we're then providing, we have bank accounts, we employ staff, we pay pensions, etc. Whether collaboratives nationally could evolve into providers, absolutely yes. I think you asked about the journey and how we've taken practices with us. It's been 10 years of hard work. The thought of trying to do that with 386 dental practices in South Yorkshire and probably the equivalent number of pharmacies, it would be a huge challenge. But there's no reason why we can't work together. And then the second bit around the changes of ICBs, absolutely yes. I think historically, PCTs, CCGs, latterly ICBs have delivered some functions which our secondary care colleagues probably just take for granted as part of their organisations. And yet they've been done by a separate organisation to primary care. Let's stick with general practice. You know, there are functions that are about the delivery of general practice, some of the rescue and support stuff, some of the development stuff. And actually, they probably would have sat better in a provider, but the provider didn't exist because historically general practice has been multiple individual providers. And I think now we're starting to talk about scale and the layers of scale critically. I think there is scope for organisations like Primary Care Sheffield to host some of those functions as ICBs evolve, and some functions drift up to a regional level, some drop down into local providers. I would hope that those that are directed towards supporting general practice delivery provision sit with a primary care provider rather than somewhere else like an acute trust or other trust.
You're quite advanced in this, where you've been doing this for 10 years, but there's places in the country where they don't have anything like this. Do you think people need to set up things like you've got?
I'm really glad that you asked that question, because I've heard it so much over the last 10 years that, but the organisations like yours don't exist everywhere. I accept that they don't, but I would also say that we're not unique. And some of the stuff that we do, we've pinched with pride from colleagues. And I've got a network of folk in similar roles to mine who we're always sharing ideas and services and pointing at each other in different directions. There's a spreadsheet with about 150 providers of scale on nationally. So they're probably in the region of 150 organisations that are doing something at scale that might not be quite as advanced as some of us, but definitely thinking about how they develop. And I would also argue that PCNs didn't exist until you stuck it in a GP contract. You know, the primary care home model was something that the NAPC were developing, and it had all sorts of evidence behind it. And then you try and roll it out across the country and then stick it in a contract. So primary care at scale, federations, for want of a better word, and I never really like it because I think that's got connotations to the past where it's been about something different. But providers working at scale in a sort of given place geography haven't featured highly in national policy over the last 10 years. And yet, despite that, almost against the flow, organisations like mine have developed, with the mention in the 10-year plan, which incidentally is a real privilege to be in there, but also slightly embarrassing because I know that there are others doing equally great stuff as PCS. But hopefully that shines a light on it. And I've had lots of contact over the last year of people wanting to sort of do similar things and wanting to understand our experience. And I think we probably could accelerate the development of that. I think it's the right thing for patients. I think if anybody understands the neighbourhood space, it's primary care and general practice at the heart of it. And I think trying to put a secondary care spin on to neighbourhoods is probably going to leave us in the wrong direction.
The 10-year plan has come out now. What are you hoping you will be able to do now it's been published? I mean, there's a lot of talk in there about these 2 new contracts. Do you see you as taking on those, or are you kind of committed to the current GP contract as it is?
We're committed to delivering the best quality of care for patients in Sheffield for a start. And I, as a GP, firmly believe that general practice is at the heart of that. You know, the ability to deliver continuity of care, manage risk, hold uncertainty, make decisions that are based around, you know, a holistic, person-centred approach, at times going against what medical evidence tells us because it's not what the patient feels is in their interests. I think that's critical as a foundation. At the same time, so I really value being a partner in a practice and the responsiveness that gives us to our list. But I also recognise that there's loads of stuff that actually we can't do as an individual practice, but that can be done at scale through an organisation like Primary Care Sheffield. My understanding is that they're not talking about GMS disappearing, certainly not at the moment. They'll support partnerships where they're working, but that coming together at scale to a 50,000 population level makes sense. And then this idea of multi-neighbourhood providers, well, we're already doing it in Sheffield. So I would see us as a natural integrated neighbourhood provider or multi-neighbourhood provider, if that's the terminology in the 10-year plan. And the plan is a relatively high-level document. The devil will be in the detail, won't it?
It's been really tough financially for general practice over the past few years. Do you think being part of Primary Care Sheffield has helped practices to weather those storms a bit more easily?
I think our business model has always been to try and ensure adequate resourcing to general practice. But we'll win contracts that perhaps are sort of a single contract for the city, and we will then push the work down to whatever layer of scale is most appropriate, whether it's locality, neighbourhood or individual practices. And what that means is that we retain income streams for the practices. Patients get care as close to home as is appropriate, but also where practices don't have the capacity or the capability to do it, their patients don't lose out because we can do it through our scale or through neighbouring practices. So I think that model has worked really well. The other stuff that we've done is sort of shared our infrastructure. So we have a cost-sharing group, for example. So some of the PCNs, we employ their staff for them. As I say, we use our finance team to manage finances for some of the PCNs. We have a training company that delivers a whole load of training, hopefully at a rate that is beneficial to the practices for not having to spend more going externally. Those are the economies of scale that do help. Has it solved the problem that the core GP contract is probably not adequately resourced? No, it hasn't. And certainly the practices, the 9 that we run, are all in very challenged and deprived areas of the city. You know, we all know that tackling inequalities is a huge issue, that actually things like the Cahill formula and QOF negatively impact on inequalities. And working in the most challenged parts of the city, we see that on a daily basis.
On your website, you say one of your big objectives is to help tackle health inequalities. How are you working to do that? Is it just the stuff that we've already talked about, or are there other plans you've got about what you're going to do in the next few years?
It's a huge ask, isn't it? Because it's far wider than just health. It's all the wider determinants. Yeah. But we're a social purpose organisation. We want to develop for local communities. All the practices that we run pretty much are in deprived parts of the city, some of them in really multi-ethnic groups. We run an asylum seekers service We run a special allocation service. In our leadership role, we champion for, more resourcing to go into those deprived communities. And the fact that I'm talking about the inadequacies of QOF on this, again, hopefully that's heard nationally. And I know in the plan, they talk about that. So hopefully that change in the way that GPs are contracted for will help with inequalities. We've done a load of work with Darnell Wellbeing, who are a community organisation in one of the areas where we run practices. So working with the local community, we've been out and used our comms and engagement team to really understand the needs of local patients, and that's work that's ongoing. And then we've got a fledgling research unit, which is really trying to just up the ante on primary care's role in research, because I think we've always been slightly less well represented in the research world. And one of the things that we're doing is working with the university around making sure that more diverse communities are engaged in research rather than just what usually happens, which is studies exclude streams of age, they exclude non-English speakers, they exclude multi-ethnicity or multi-morbidity. And all of those are the patients that we're dealing with on a daily basis in general practice. So we're trying to sort of shift the dial on that as well. We haven't got really clear answers and it isn't easy, but we're trying to sort of pushing on a range of fronts just to try to keep that agenda going.
Do you think that, working at the scale you are, at scale, is that easier to deal with health inequalities rather than individual practices trying to do everything on their own?
I think it has to be complementary. What we've done is we're not about replacing one level of scale with another level of scale. You asked again about how do you engage practices in this? Has it been easy? One of the things that we've had to repeatedly say is we're not here to subsume practices. I think at times across the country, BMA or LMCs have been worried that at scale primary care provision is a threat to core general practice contracts. That's not what it should be about. What it should be about is actually by working together in an integrated way, interdependently across the layers of scale, you massively increase the capability and the capacity of general practice. You can have the best of both worlds. We might have to flex the model slightly. It won't always be how it used to be. You can have that responsiveness and the continuity of care for those that need it most, the most complex. But at the same time, you can have services that are delivered at a slightly different scale for patients that don't need that continuity, that are less complex. And it's not about cherry picking. It's about just accepting that there are different cohorts of patients. And I think the plan picks this up. Different cohorts of patients need different approaches. And if we start to acknowledge that and grasp that nettle, I think we can be even better at what we do than we are now. Sheffield is a very diverse city and we've got huge health inequalities. Life expectancy gap across the richest and the parts of Sheffield, huge. If you live in the worst part of the city, the poorest part of the city, you're going to spend 20 years longer in ill health compared to the richest parts. And the way that you design and deliver services can't be the same in Dore and Darnell. It has to be different.
We're at the start of this 10 years where everybody's going to be working in a neighbourhood way at some point over the next decade. In your area, what are some of the key challenges that you think will need to be addressed to deliver a truly neighbourhood NHS? Do you have the estates and the workforce you need, do you think?
Estates is a really good one to start with, isn't it? Primary care estates particularly are a challenge. And when I started in general practice, the district nurses, the health visitors, the mental health workers, and at times the local hospice nurses used to come in and they were based in the practice or came in regularly. We knew them personally and now they're disparate and we don't know them personally. And that's a real shame. But that's also the fact that the general practice workforce has ballooned and we've not got any space in our buildings. So I'm really pleased that the plan tackles that. I think it has to be about looking at void space, repurposing other buildings, looking at the amount of both local or authority and other NHS estate that currently is underutilised. I suspect it could be about shiny new buildings. We run some of our services out of PFI buildings and we know how prohibitively expensive they are if you want to do anything that's outside of the existing lease. The way that we fund any new builds have to be different. How do you get sort of public partnerships so that the funds and the benefits of new builds go back into local communities rather than sort of outside of the NHS? Health inequalities we've mentioned, but it would have been one of the things I'd have mentioned around, how do you meaningfully tackle it? We all talk about it, but it is a real challenge. We know that the wider determinants of health are a problem. I'm really agitated by the ageing population. If you look at Chris Whitty's report a couple of years ago, something like 25% of the population will be over the age of 75 by 2043. That will have its own requirements. I think another challenge is demedicalisation. So we over-medicalise lots of things. Something like 43% of the population die in a hospital bed. An 8-year waiting list for kids in Sheffield for ADHD, ASD diagnosis. So if you're 8 now with symptoms, you'll be 16 by the time you get assessed at the moment. And that's not a criticism of anyone. It's just a recognition of the challenge. I think the government's on the right track with talking about neighbourhood health and empowering patients and thinking differently about how communities manage their own care through peer support and health coaching and so on. I think the challenge will be getting the NHS to recognise that actually it's okay to demedicalise some of this. It's really interesting that the plan talks about personalised health budgets. You know, a year of care for somebody with multiple long-term conditions and how they want to spend that in the last years of their life would be really interesting.
You mentioned that there's obviously quite a lot of other people doing what you're doing. You're not unique. But if there's anyone listening to this who's kind of early on in their journey of working in a group at scale, what sort of advice would you give them about how to go about this?
There's more than you'd imagine. And my experience is that all of the people leading those organisations are very willing to have conversations and help and to share. So firstly, speak to people that are already doing it. Be rooted in the practices. You know, this has to be done with, not done to. It's not about taking over or replacing. It's about recognising that by working together collectively, we're sort of greater than the sum of the parts. Work with your LMC. They have to be a critical friend. And to LMCs, I think, be open-minded. To the practices, you can't govern by committee. So work out how you're going to develop it, how you're going to lead it, and then empower those leaders to get on with it on your behalf. There's something about building strong, transparent governance so that your leaders can be held to account. And remembering that actually leadership's really lonely. It requires quite a lot of courage and people are stepping way out their comfort zones. So be compassionate with each other, respect each other, and relationships and trust are key to delivering any of this. At times it feels like we're being slightly competitive with other parts of the system. I think that's just because primary care always feels like it's the poor cousin. Lots of systems are dominated by secondary care, but at the end of the day, the best thing for patients is us as system partners working together in sort of collaboration. So build those relationships. We can't do it alone. There's plenty of work to go around for all of us. And then finally, and probably most importantly, I always remember that patients are at the heart of it. You know, if you think about patients, then you'll design the right services, engage patients in it from the start, you know, ask them how things should be, and you probably won't go too far wrong.
Do you feel positive, hopeful about the future now this plan's been published? Do you think there's good things coming for general practice?
I feel positive about the high level sort of direction. I don't think anybody could argue against the hospital to community shift, push towards more prevention, upstream working, and let's accept that digital and data has to be in there. We have to be tech enabled. I would argue that we need a strong foundation of IT infrastructure first. There's no point in talking about the fancy AI stuff if we haven't got computers that work with the current programs they're running, and that is an issue. Again, I think the plan does acknowledge that. I do feel positive about the future. I think this recognition that actually across the layers of scale we can do even more in general practice. And hopefully this is, the plan talks, doesn't it, about a new era for general practice. And I truly hope that it is a new era for general practice. I am an optimist, but we're going to have to change. It's going to have to evolve. We can't stand still. I'm really passionate about the value that general practice adds to the system. And I think often it does go unrecognised. There is a wealth of national and international evidence that demonstrates that good quality general practice and wider primary care is not only the best thing for patients, but also reduces year-on-year growth in spend on health. There's lots of stuff that's gone before about the shift from hospital to community, and lots of us would be saying, well, it hasn't happened yet, so what's going to be different this time? But I think it's up to us to make it different. And I think to a degree, some of the recognition of working across those layers of scale, perhaps that is the different thing. And we need to get on and organise ourselves and do it. And that protects things like continuity of care and relationship medicine and some of those core values of general practice that we don't want to lose, that patients value and we value as professionals.
Brilliant. That's a really great place to leave it. Thank you very much, Andy, for speaking to me today. Thank you.
Pleasure. Thanks for having me.
Well, that's it for this week. Thanks for listening, and thanks again to Andy for taking the time to talk with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news and access a wealth of other resources on our website at GPonline.com.